I welcome you all to the next edition of Winning Decisions in Orthopedic Surgery presented by the Bombay Orthopaedic Society. This is a series of webinars in which eminent members of the Bombay Orthopaedic Society share their vast experience and wisdom with all of us. Today, we have one of the leading spine surgeons of India, Dr. Ram Chaddha, with us. Apart from being the past president of the Bombay Orthopaedic Society, he has also been the past president of the Association of Spine Surgeons of India and the Bombay Spine Society. He is the council member of the Asia Pacific Orthopaedic Association and the chief national delegate from India at the Asia Pacific Spine Society. He has been in practice for the last 30 years and practices in Lilavati Global and Jaslok hospitals in Mumbai. Today he is going to tell us on how to make correct decisions and follow an algorithmic approach when dealing with lumbar degenerative disorders. Please join me in welcoming Dr. Ram Chaddha. Over to you, sir.
I thank the Bombay Orthopaedic Society for giving me an opportunity to share what I have learned from my patients, my peers, and my colleagues as regards managing low back disorders. Low back pain is something which 80% of human beings would suffer with at least once in their lifetime, if not more. It's the commonest cause of any disability in less than 45-year individuals, both men and women. Low back pain broadly can have three major causes: lumbar disc herniation or slip disc, lumbar canal stenosis associated with claudication, or lumbar canal stenosis plus a few other entities clubbed together, complex lumbar canal stenosis or lumbar canal stenosis plus. Let's look at lumbar disc herniation, something which most spine surgeons, most orthopedic surgeons see in their daily practice. We are confronted with many a patient who comes and says that she or he has a slip disc. This is related to or addressed as any situation with low back pain radiating down the buttock, thigh, or calf, and associated with some history of abnormal movement in the lower back. This is related to a disc protrusion or a prolapse, which may or may not irritate or compress a nerve root in the lower back. All biomechanical and pathoanatomical changes in the disc associated with degeneration, right from a bulge to more than a bulge, from a contained disc to a non-contained disc herniation, are all clubbed under a slip disc. Broadly, let's look at contained and non-contained discs. A contained disc or a protrusion is a bulging of the disc whose annulus fibrosus is preserved. Intradiscally injected contrast, if ever given, would remain contained, hence the name. What's then a prolapse? It's a non-contained disc which involves complete perforation of the annulus fibrosus and an expulsion of the nucleus pulposus from within. Hence, if contrast were to be injected, it would be non-contained. What's then a degenerated disc? A degenerated disc is a contained or a non-contained disc that has lost its water content or proteoglycan, which is within the nucleus pulposus. It's a state of altered morphology, hence compromised mechanical efficacy of the disc, in which the disc is unable to transmit loads across the vertebral axis, which means it does not function as well as it ought to as a shock absorber. That's a DDD, or a degenerated disc disease. It's believed to be not necessarily related to a single inciting event, but multiple complex interactions of biologic and biomechanical factors. Let's look at a schematic representation. We have a nucleus pulposus in the center, proteoglycan or water content. We have an annulus fibrosus with crisscrossing collagen fibers. And we have hyaline cartilage over the end plates of the vertebral bodies above and below. This is how the infant is born with a disc. There is some blood vessels which percolate in there in a child and an adolescent. The hyaline cartilage gradually thickens. The annulus gets stronger. And over a period of time, the nucleus pulposus develops clefts. As a young adult, these clefts become bigger, wider. Clefts may then become tears. There is a reduction in the disc height secondary to the water content or the proteoglycan moving outward. Extensive clefts form. Nucleus pulposus gets disorganized and there is osteophytosis. As we age, we go through dysfunction into an unstable situation in the lower back till finally it auto-stabilizes. This is a universal phenomenon and is represented by a Kirkcaldy-Willis cascade of events. What is the basic structure of the disc? There's a tough annulus fibrosus, mainly collagen on the periphery, and a gelatinous nucleus pulposus with proteoglycan in the center. The normal nucleus is distortable, but effectively compressible semi-fluid mass, which is held firmly in place by its surrounding annulus. On loading, fluid is expelled from the annulus and goes into the nucleus. The centripetal fluid shift in the loaded disc results in the nucleus pulposus, which has abundant water content, causing permeability during the early phase of loading, and there is a push outward. There's a maximum chance of disc injury when the annulus is vertically loaded. This makes the disc stronger. However, the turgid and spongy disc can be injured when it is vertically loaded. What does this then entail? What causes the disc herniation structurally? A tear in the annulus fibrosus and a migration of the nucleus pulposus from the center outward. What does this cause in turn? It causes nerve root pressure, which gets translated into leg pain or radiculopathy. Schematically, nucleus comes out and irritates the nerve, usually on one side. It goes through the dysfunction, unstable, and stabilization phase, not just in the disc, but in the facets, and follows clinically. Let's look at a straightforward case of slip disc or lumbar disc herniation. 45-year-old gentleman, 4-day history, severe right more than left leg pain with L5 dermatomal representation. Neurologically, L5 nerve root involved, let's say extensor hallucis longus and extensor digitorum longus, grade 4/5 power. It would be very, very exciting and would be something that most people would want to do. Go in and pick up that fragment immediately. But let's have a discussion. Should we conserve this patient, 45 years old, or should we operate on this patient with a mild neurological deficit of 4 days onset? I would make my case of not suggesting an immediate operation. Why would we think of it this way? What is the natural history of a herniated disc fragment? There are numerous studies, a few of which I shall quote, which say that herniated discs subside in majority of cases. 75 to 100% resorption in 49% situation. 50 to 75% resorption of the disc in 39% resorption, which means that majority of discs would reduce, if not totally shrink and disappear in a very, very short period of time. Why does this happen? Because the nucleus pulposus, the fragments which come out, they initiate an inflammatory response. Interleukins and prostaglandins cause macrophage infiltration and neovascularization, and the disc tends to get resorbed, shrinks, and disappears. More interesting, larger disc herniated fragments shrink quicker. More degenerated the disc initially, it shrinks or resorbs much better. It's in fact the young contained disc bulges which do not regress as well as the elderly disc extrusions or non-contained discs. There is no correlation between the site of herniation and regression. Let's look at a simple situation next. Do epidural injections increase disc regression? There is no difference in degree of regression whether you inject saline, steroid, or chymopapine. Does radiological regression correspond with clinical symptoms? Interestingly, clinical findings will improve much before changes in MRIs. And if you really do study MRIs serially, you will realize that complete disappearance of the disc causes complete disappearance of symptoms. A marked decrease also resolves symptoms. Slight decrease also resolves symptoms. In fact, it's only in those patients where there is no change in the MRI finding who still tend to suffer at the end of 150 days of the pathology. So what's the natural history of symptoms? Well, truthfully, there aren't many randomized studies because one, the indications for surgery are usually cauda equina, intractable pain, progressive neurology. While on the other side, those who opt for conservative arm, these are people who are averse to surgery in the first place. So there is a selection bias, and hence you cannot really randomize these patients. It would be unethical in forcing an unconvinced patient into surgery or denying surgery to a patient with neurological deficit. Hence, there is no such randomized study really available. But 90% of patients managed conservatively have fairly good results in 1 year. Conservative group, they receive rest, bracing, paracetamol, pain medication, whatever you may try. The natural history says that 60% of patients who've undergone surgery will feel better in the first year, and 90% with surgical group as compared to those who have not undergone surgery. At 4 years, the difference between non-surgical and surgical comes closer. But at 10 years, truthfully, there is no difference between conservative and surgical management of lumbar disc herniations. So as we see, as we get away from the time of surgery, or as we get away from the initial episode of non-surgical care of lumbar disc herniations, the results remain to be very similar. Do we have any study which tells us that a particular NSAID or non-steroidal anti-inflammatory works? Truthfully, piroxicam was compared with the placebo, and there was no difference between the use of the NSAID versus the placebo. Do epidural steroids affect the natural history? Well, they may give immediate symptomatic relief, but there is no significant difference in long-term results with or without use of epidural steroids. Now, interestingly, at 1 month after surgery, well, patients would feel much better than those who were conserved. At 1 year, it gets closer. At 4 years, it gets even closer. And at 10 years, there's hardly any difference between surgical and non-surgical results. Hence, take a thought and think twice before offering surgery to a patient with lumbar disc herniation. Well, let's look at the natural history of those patients who have mild neurological deficits with lumbar disc herniations. I'm not talking of the Cauda equina group. Overall, they have a good prognosis. Recovery is seen in the first few weeks after the onset. Sensory fibers are the most susceptible to compression and hence the last to recover. Resolution is not affected by surgery, is what Weber said in 83, and a lot of us still believe in that. Very interesting findings. What are the positive outcome factors, whether surgical or non-surgical? Absence of a cross SLR, spinal motion in extension not mimicking symptoms, large extrusion or sequestration, good result, relief of 50% pain in the first 6 weeks, good fitness level, progressive improvement neurology in the first 12 weeks, and a motivated, no psychological issues, self-employed patient. What are the poor outcome factors? A positive cross SLR, leg pain produced even in extension of the spine, contained subligamentous discs, not recovering beyond 50 degrees of leg pain in the first 6 weeks despite non-surgical care, progressive deficit of cauda equina creeping in, psychological issues, patients with work compensation, and the unmotivated patient. Well, those factors which do not affect prognosis at all. Degree of SLR. Doesn't matter whether you have a 30-degree or a 70-degree positive SLR, whatever you may calculate it, it doesn't affect it. How long you give them bed rest doesn't affect. How they respond to passive physical therapy doesn't affect. Age and gender of the patient, nothing. Neurological deficit, yes. Unless it's a progressive neurology or a cauda equina, these patients will not have a significant difference. A mild grade 1, which is 4 plus or a 4 on 5, does not make much of a difference as far as recovery is concerned. So in summary, most disc herniations will spontaneously resolve. Large migrated herniated fragments will resolve better than smaller protrusions. Majority of patients show spontaneous improvement in the first 1 to 3 months. Remember still that you have to operate in cauda equina. Profound deficits like foot and ankle drop, toe drops, unrelenting pain, not responding to medical management, and the patient cannot live with that. It's disabling their activities of daily living. These are the people who need surgery. Let's now look at when we give them surgery for that limited indication of patients. These patients could be young active patients who mainly have leg pain, middle-aged patients who have a combination of leg pain and back pain, or the elderly sedentary who have mainly back pain but is associated with some claudication. How do you clinical radiologically correlate them? Well, after a clinical examination, they are subjected to X-rays, flexion extension views if necessary, an MRI on a 1.5 or a 3 Tesla, a CT scan if necessary, electrophysiology, discography, and psychosocial evaluation in limited number of patients. Treat the man and not the scan. Go with a clinical judgment whether this patient deserves an operation or conservative care, and use the principle of miracle. Minimal invasiveness, risks, and cost having a lasting effect. MIRACLE. Symptomatic discs need psychosocial evaluation. They have to alter their behavior and need behavioral therapy. A few of them may respond to spinal manipulation, activities of daily living modification, and physical therapy modalities. Various physical therapy modalities and ADL modifications are available. Surgically, different people do different things. Do what works best in your hands. Disc deflation, laser, APLD, chemonucleolysis, ozone. These are percutaneous procedures which just shrink the nucleus pulposus. Truthfully, I am not very, very keen on these procedures. I generally look at these patients as those who don't need any operation, and hence, if you are one of those who responds dramatically to a laser, APLD, or ozone, probably you're one of those who would have responded to just about waiting for some more time. Hence, those people who do profess excellent, miraculous results with this are probably treating contained discs in the very, very early stage, where a patient wanted a procedure to be done rather than those who could have been sort of treated with some reassurance, empathy, and compassion, and given some more time to resolve. When then do we do disc surgery? Cauda equina and progressive neurology. Well, you could do it microlumbar decompression through a tube, through a small incision, using a Destandu system, using a tube, using a McAuliffe retractor. This is a posterior endoscopic discectomy using a Destandu tube retraction system. You could do anything from a fenestration discectomy to a laminotomy to an interlaminar discectomy. We do not, for a disc, do a huge laminectomy anymore. That is reserved for the multi-level compressions in lumbar canal stenosis if necessary. How much of the disc should we remove? Never be over-aggressive. Remember, it is not a disc surgery. It's a nerve root decompression surgery. So anything and everything which is causing compression along that nerve root, including ligamentum flavum, including a part of the lamina, including the undercutting of a facet, including osteophytes, and the disc fragments, soft or hard, which is indenting, irritating, compressing that nerve root, needs to come out, not just debulking that disc and getting that disc out completely. Do just a bumpectomy, remove the loose fragments, never do a total nucleotomy, don't do a complete nucleotomy with a radical annulotomy, and gone are the days when we did curating of the end plates. If we do that today and leave that patient without an instrumented fusion in the lumbar spine, we are probably looking at and inviting aseptic discitis or septic disc infections. Microlumbar discectomy, if well done, would show a pre-op and a post-operative MRI like this through small incisions. Sagittal view shown earlier, axial view shown later, just to show how much you can clear off the patient's neural elements. Let's look at the next level, a middle-aged patient who has a combination of back pain with a VAS of 4 on 10 and leg pain 6 on 10. So you need to treat both the back and the leg pain. Well, in these patients, about 15 years back, I used to do decompressions with stand-alone fusion devices, which were expandable devices. So I extended my microlumbar decompression through McAuliffe's retractor, used local autograft, did a complete disc clearance because there was a settling down of the disc, plus there was significant back pain related to or looked at as coming discogenic in origin, and I put in standalone B-twin expandable devices, not available anymore, but I'm sure similar products would be launched sooner or later. This was minimally invasive fusion, done and did stand the test of time for a prolonged period of time. Now let's look at the elderly sedentary, where you have back pain, leg pain, bilateral pain, going from axial back pain to early element of canal stenosis, but where it's mainly back pain related, not much of a sagittal instability. In these patients, we did decompression, instrumented stabilization, more for back pain as well as clearance of the nerve roots bilaterally. We used autograft, we used mesh cages, we used to do complete central decompressions, use that autograft, look at the nerve roots bilaterally, put in that mesh cage and roll it one side, the more affected side, or two separate sides. So it was a T.L.I.F or a P.L.I.F, depending on what we wanted to do. But we had to be very careful of red herrings like the bifoot root, the double root, and of course, look for those synovial cysts, which may at times be adherent and may mimic disc herniations and add to the nerve root compression, usually on one side, but rarely bilaterally as well. Coming to that part, which probably excited me a lot and still is probably the future. Do all degenerative lumbar disc lesions need a fusion? Are there soft stabilization options available? Yes, there are. We did use a lot of them where we would decompress two levels, but we would fuse just the lower level where there was an instability and decompress and do a more sort of fused upper level, allowing some physiological movement. So we would put in a flexible rod either above or below the fused level, where we would allow some amount of movement, but not hyper movement. Hence, we try to mimic normal physiology and allow normal function to the patient. Well, disc replacement did come for some time, was an excellent solution. I'm looking forward to it coming back again. The problems of disc arthroplasty were more access related rather than those related to the biomechanical part of the components. I've not really used interspinous spacers as much. I'm not too convinced about the efficacy, but if there is a way to go, these are both non-fusion options and refined versions of the two, if they do come in the future, may be viable options. My last word as far as disc herniation is concerned, contained discs, which were protrusions, not prolapses. They should be treated non-surgically in the first episode. You can use help of a physiatrist or a pain specialist, minimally invasive options. Do not offer them surgery, but if they are in incapacitating pain and only then in agony, they buy the operation, give it to them, but don't sell the operation to them. Non-contained discs, those causing early or deep deficits which are disabling them, motor and sensory. Give them minimal access decompression as far as leg pain is concerned, and do not offer them fusion to begin with. Just do a minimal access decompression of the nerve root and get that fragment out. Coming to the second commonest cause, which is lumbar canal stenosis. This is basically interpreted as neurogenic claudication, where you get severe buttock, thigh, and calf pain. Patients are elderly, they tend to stoop forward, the classic shopping cart sign. They walk short distances and they need to sit down and stop. Again, they could walk those short distances again. The claudication distance and time regresses as the disease progresses. When should you break this claudication cycle? Well, all these are a part of the calcaudibulus cascade. Initially, there is micro instability, then there is a settlement or macro instability before they will auto-stabilize. But in that stage between micro to macro instability, they are extremely painful and uncomfortable. At this time, if they are significantly claudicant, they could be offered surgery after a good non-surgical trial. Please understand, we should not necessarily wait till they develop bladder bowel sphincter symptoms, vesicorectal issues, which will probably give them a bad result in the long run. Hence, offer them surgery when they really deserve a decompression. 83% of patients with neurologic claudication or vesicorectal symptoms deteriorated with poor final outcomes. So don't wait till they get that bladder bowel symptoms. Please offer them surgery earlier. And this is what Matsunaga realized when he did a huge study in 1993 and retrospectively felt that these 83% patients should have been offered surgery. When do you break the cycle? Well, when that canal is really, really badly compressed radiologically, and this is in addition to clinical severe claudication where patient can't really walk beyond a few steps, and you've ruled out the vascular causes. So that's extremely important as well. And at times there's a correlating central as well as a lateral or a foraminal, extraforaminal disc, which may be adding to this problem. We had in the earlier days options of doing myelograms, which were dynamic studies. Today, an MRI gives us as much, if not more information, and we can go ahead and do a decompression both centrally as well as laterally after studying the central cuts on sagittal as well as the foraminal cuts, and if they are involved, do suitable decompressions as needed. When do we break the cycle? Well, we do it when things go from push to shove. They become really, really bad. Unbearable, clearly interfering pain, not relieved with conservative treatment for about 3 to 6 months, gradually shortening walking distance, progressive neurological deficit, bladder bowel now getting involved, cauda equina coming in. Well, these are situations where you have to offer them surgery. Well, what do they need? Most of them need decompression alone. A few of them will continue to worsen despite just the decompression and have progressive neurology and bladder bowel. Well, in those situations, you should be aware that decompression alone will relieve the neurological and radicular symptoms. But for how long? What about the back pain? If the back pain is attributable to a significant instability, like we see in this image on your right, which is an L4, 5, or a 3, 4, whatever you want to call it, instability, then in that patient, just a decompression would not work. In fact, it would make matters worse, as it did in this patient. Please understand that when your decompression is associated with a further medial or more than medial facetectomy, in those patients, only 30% will do well. Well, where you preserve the facets, 80% will do well. And where you've done a decompression, preserved the facets, and added posterolateral fusion, 90% of those patients will do well. Yet, do well for how long? For a short period of time. In about 3 years, 36% of these posterolateral fusions will develop pseudoarthrosis, and the patient will come back with symptoms. So decompression alone has shown to give additional bone regrowth and restenosis as compared to arthrodesis, of ensuring arthrodesis. Hence, from decompression, we move to posterolateral fusion, and then we move to instrumented posterolateral fusion. But this came with higher cost and complication rate. Yes, we could also better align the sagittal contours of the lumbar spine. Yet it had its own set of bad luck, complications, and poor results. So some people tried to do this from the front, an indirect decompression with an anterior lumbar interbody fusion. Well, this had its plus points, but had negative points as well, where it had higher cost and complication rate, which was related more to the axis. So then we combined the two. We started putting in interbody devices and correcting these deformities from the rear itself rather than going from the front, doing T.L.I.Fs or P.L.I.Fs. We got elderly patients who also had osteoporosis. So we worked them up, improved their bone quality by using anabolics like teriparatide, and we ensured fusion by using RHBMP2, a bone morphogenic protein. Having done all this together, we got reasonably good results, even in fragile bones, where we used teriparatide, we used cement augmented screws and wires and bands, and probably we did all we could to keep these elderly people, well, dignified and living a good quality life. Finally, coming to lumbar canal stenosis plus, which is complex lumbar canal stenosis. Those associated with degenerative listhesis, degenerative scoliosis more than 20 degrees, and redo or revision surgeries. In all these patients, you have to wait and stare for a little longer. You have to introspect, look deep, and realize that there is an instability, as you would appreciate if you were to concentrate on this slide for slightly longer. There is some movement which we have to look for. Let's begin with degenerative listhesis. You could have done a standard lumbar decompression, but having said that, that lumbar decompression didn't work, ended up with a bigger listhesis, and we had to do an instrumented fusion, a redo at the end of 3 years. We did stress dynamic x-rays in degenerative listhesis, found that they are mobile, and we put in fusion devices, interbody, P.L.I.F or T.L.I.F. In this case, it was a P.L.I.F, but today I would do just a T.L.I.F and leave this patient alone with one spacer rather than two. The other thing we learned, that posterolateral fusions tend to disappear while interbody fusions tend to have dramatic bony fusion. Hence, I am one of those who's a very strong proponent of interbody fusion rather than posterolateral fusion, And I'm not one of those who today at any stage would do the 360-degree fusion. If I'm doing interbody, I would not do posterolateral anymore. And if I were to still do posterolateral in a view, which I would show there, I would probably not put an interbody. This is one of those where I do only a posterolateral, a degenerative scoliosis with more than 20 degrees, but not significant sagittal shift. There's not much of pro and retro listhesis. There's a lateral listhesis to a certain extent. So in these patients, a central and lateral canal stenosis decompressed, put in your screws and do a copious posterolateral fusion. While those where there's a significant interbody instability in sagittal plane as well as coronal plane, well, these are the ones who would need posterolateral, but more so interbody fusions to correct the deformity and maintain it with as short as possible. Redo or revision surgeries, you'll have to go in again, you'll have to sort of sacrifice the facets, do large facetectomies. In these patients, you may probably have to do instrumented fusions, especially if these are late recurrences where you have to actually get in and get a lot of scar tissue out and sacrifice a lot of bone, where only a revision decompression may not work. In those with implant failures, etc., with significant secondary canal stenosis, in these redos also, you have to explant the old metal and get in and put a fresh set of metal and do interbody devices and do a complete decompression and stabilization and hope for the best. What lessons have I learned? When to break the claudication cycle? If patient has symptoms more than signs, let the patient buy the surgery. If he has signs more than symptoms, neurology, that you have detected, offer him, counsel him about the surgery. In the elderly osteoporotics, always supplement or complement your treatment with aggressive medical management, maybe in the form of calcium, vitamin D3, bisphosphonates, denosumab, or teriparatide. Complex lumbar canal stenosis, scoliosis, more than 20 degrees, listhesis, redo surgeries. In all these, remember, less is more. Don't be too aggressive and don't go for the overkill. If you're using instrumentation in these patients, think of cement, think of BMP, think of fenestrated screws, even think of wires and bands. Use technology and technique. Use artificial intelligence, get the RoboNav. If you can, get navigation, get minimally invasive surgical techniques in. Always do these patients where you have good ICU backup, where the comorbidities can be sorted out. And finally, read the fine print. Decompression primarily relieves radicular symptoms and neurogenic claudication, whereas fusion primarily relieves back pain. The goals for instrumentation are to promote fusion and to correct deformity. Fusion has a better long-term outcome than decompression alone. There is evidence that instrumentation improves fusion but does not improve clinical outcome in the short term. However, outcome of pseudoarthrosis cases deteriorates over time and solid fusion produces better long-term outcome. The benefit of instrumentation comes with the price of higher postoperative morbidity and complication rate, and in our country, the cost. BMP has been used and increases the rate of fusion, but it also may cause prohibitive increase in costs and now probably an increase in complication rates also. More recently, dynamic stabilizations like the ones I shared with you, well, with instrumentation but without fusion, would be introduced as an alternative modality of treatment. Love it or hate it, non-fusion is here to stay and will stay for good. The future, well, I don't know. Fusion versus non-fusion, minimally invasive versus open, instrumented versus non-instrumented, gene therapy versus biologics versus metal, or is it going to be cost effectiveness versus safety? My guess is as good as yours. I can only tell orthopedic surgeons, my dear friends, tread cautiously into spine surgery, for things are changing as we talk, and what is state of the art today will be history tomorrow and obsolete the day after. Do what works best in your hands rather than be market driven or techno savvy. I only suggest that you practice spine surgery which is safe and try and make unhappy patients less unhappy. Thank you very much for a patient hearing.
Thank you, sir. Thank you very much. Thank you for an excellent talk on this common problem. I'm sure the audience would have gained a significant wisdom and pearls from you. If there are any questions, please try to put them in the comment box below and we'll try to get them answered as soon as possible. Hope you all enjoyed this webinar, and on behalf of the Bombay Orthopaedic Society, I once again thank Dr. Ram Chaddha for his efforts and enthusiasm, and thank you once again. Bye.
Thank you.